director of the Nurse Family Partnership here in Central Alabama. There are actually 3 agencies across the state. There's one in Montgomery called Gift of Life, and then there's one in Tuscaloosa as well, out of Easter Seals. So we are a relatively new player in this field. We've been up and running. We just had our first birthday. So Julie, you missed birthday cake at our last meeting. We had birthday cake. I know. I'm super excited to be here. I feel a little bit at home with all the familiar faces that I see. We've been working pretty closely with the School of Public Health, so I'm excited to be here. So a little bit about Nurse Family Partnership. We're new here in Birmingham, but the agency or the model itself, model of care, is about 40 years old. It started out in Denver. I'm at the University of Denver with Dr. David Olds, and he did some trials in Elmira, New York, and then in Memphis, Tennessee. So with 2 different types of populations, and that model has been implemented all over the country in all but 7 states. So we're lucky to have NFP here in Alabama. So we received our funding. We've got 3-year pilot funding from these philanthropic donors and the Jefferson County Department of Health. So but we are really excited to also have some McVie funding and some state funding as well that we've received recently for some expansion to Walker County. So I've got some cute pictures in the first of this, so y'all can feel free to ooh and ah. Sweet baby pictures. So why NFP? There are a lot of models that touch the lives of families who are involved in maternal child health. NFP is one of them, and it has some very specific eligibility requirements. We see first-time mothers, and one of the reasons we see first-time mothers is that usually when they come to the table with a first baby, they're very ready to learn, they're eager to learn. They don't have this, oh, well, I've done that and I did it this way and it worked, so why do I need to put the baby in the car seat? They don't bring that with them to the table. So one of the reasons that the research shows that this model is so effective is that it's with first-time mothers who are very eager to learn and receptive. One of the other things is that we exclusively use nurses for this intervention. So don't be offended, because there aren't very many nurses. Are there any nurses in this room? Any nursing students? Are you one of ours? Yay. Okay, good. So don't be offended if you're not a nurse. This is a very nurse-centric model. Nurses bring to the table a lot of knowledge and experience with the maternal child health population. These aren't new nurses. These are nurses who've had significant experience in the field with maternal child health, typically labor and delivery or postpartum, pediatrics. It's not exclusively the case. Actually, I've got a nurse on our staff who has experience with mental health and some home visiting in other settings. But these nurses have a lot of health knowledge. But one of the things that people don't know a lot about nurses is that we're also really good with education. And we look at our clients instead of in a medical model where a physician may look at a patient for a diagnosis and treatment. A nurse looks at a patient in a little more holistic way, and so that's why a nurse is a great fit for maternal child health home visiting, because we're looking at the patient. We call them clients. We're looking at them in a very holistic way, and what are the other pieces of this puzzle that either help this patient to move forward or prevent them from getting the care that they need to have. So we also serve mothers who are impoverished. So the eligibility requirements for our program include being a first-time mom, income that makes you eligible for Medicaid. That's our income requirement. And so that makes you impoverished. That means that you live in poverty. And that also means that these moms have a lot of risks. They may or may not have finished school. They may or may not be working or have the ability to get to a job. They may not have transportation. So a lot of barriers come into play, and that typically makes them very high risk as far as parenting is concerned. So, specially trained nurses. I talked about that a little bit already, but these nurses also go out to Denver for a week-long training, and we say they go out and drink the Kool-Aid, because when you come back from an NFP training, you're like, oh, this is the best model in the world. There's no other way to do this. So that's it. You'll get that. You'll probably hear that from me. It is a great model. One of the reasons I think it's such a great model is that It differs a little bit from how we typically interact with our patients in the hospital. I don't know if any of you have been in the hospital, but if you have, you may have heard from a nurse or a provider that, well, you need to quit smoking because it's bad for you. And the patient promptly goes home and continues to smoke because that didn't really remove any of their barriers or really give them any other motivation to quit smoking other than, well, yeah, I already know it's bad for me. I've seen the commercials. That didn't really change a whole lot about my life. We use motivational interviewing to interact with our clients. So if we encounter a client who does smoke during pregnancy, it's not just well, you need to stop. That's bad for the baby. There's a lot more to it than that, and we know that the client has to come to that on their own for their own reasons. And so we work with them and support them in their own goals, not our goals, not the way that we think that their life should be, but the way that they think their life would be better. And so we work with them on meeting those goals and figuring out what those goals are for them, because a lot of them just don't know. I don't really know where I need to be or where I want to go. So we can help them to develop those goals and get there. It's proven. So like I said, there's 40 years of data behind this model, which is really compelling. It's the gold standard. You're going to talk about PAT, aren't you? No? Oh, okay. So NFP, and when you look at the literature, NFP is the gold standard of home visiting because of the data and because of the outcomes. It's intensive. So we see clients, we have to enroll them by the time they're 28 weeks pregnant. And we see them until baby turns 2. So we have about a 2.5-year relationship with these clients, and we see them every other week, basically every other week for that entire time. So it's up to 64 visits if they meet every visit. It's rare to have a client that meets you every 2 weeks, but that's the standard visitation schedule. It's timely because it's that first 1,000 days. Okay, we're seeing them prenatally, and that really important piece of that brain growth and development. So we're getting those first 1,000 days, and we're teaching them not only about how, what to expect during pregnancy and the things that would really be healthy for them, but also how to be a parent. A lot of these moms don't have a model at home. They don't have that mom who read to them, who tucked them in at night, who didn't use really negative touch when they were punishing or disciplining their children. So we're there to model, and we're there to help them, to actually provide them with some developmentally appropriate toys and books and things to support that. So it's a very global intervention. We're also there to help mom get a job if that's what she wants to do. We help them fill out job applications. We do a lot of different things for them. So like I said, very global intervention. Not in the sense of international global, but well-rounded. So what are our goals? Our goals are to improve pregnancy outcomes. You probably have read and know that Alabama has the highest infant mortality rate in the nation, which puts us pretty high up there with developed nations, one of the highest among developed nations. I think the last statistics I saw, we were second to Mexico. We were just right below Mexico. We also want to help them improve their child health and development. We're talking to them about breastfeeding, about getting their immunizations. Did you go to your 4-month visit? Did you go to your 2-week visit? Those kinds of things. We're helping them meet those goals and helping them find transportation if they're not getting there. And then finally, improve the economic self-sufficiency of the family, because we all know that without that job training and ability to bring in income, that it's going to be really difficult for this family to move forward and be successful. So that's one of the really important goals, and that's one of the ways that we've been really successful here in Birmingham is we've partnered with a lot of other agencies who are helping these women get their GED, finish their education, and find jobs. These are some of the assessments that we do. That's why I said it's very global. We're doing physical, social, environmental, family history, that's kind of an ongoing thing. We do mental health assessments. We do anxiety, depression, those kinds of things. And then, of course, the ASQs and developmental assessments as well. The dance assessment is something as a dyadic assessment of naturalistic caregiver engagement. There it was. That was that last letter, which is a really, really robust assessment of how mom and baby interact with each other. And a lot of our intervention is based on that. We give them anticipatory guidance on all of these things and more. So there's a lot of education that goes on within these visits. We spend an hour to sometimes 2 hours every 2 weeks sitting in the home with these moms and talking to them about what's going on in their life and all of these things as well. So there's a big relationship piece. One of the things that makes this work is our ability to reach out to other community agencies and refer if we need to. So we're also communicating with the provider. So if we go in and check a blood pressure and it's high, we then can call the provider and say, hey, make a note in your chart. Do you want to see her, or do you want to just follow up at her next visit? How do you want us to handle this? So we're communicating with the OB provider, the pediatric provider as well. We communicate very frequently with the social workers. We get a lot of our referrals from the social workers and the Steps Ahead coordination system. And we communicate a lot with them because they're seeing the clients as well and making sure they're not missing anything and we're not missing anything. Because one of the things we found is that we sometimes hear a little more than the social worker in the office hears because we're sitting in the home and we've developed a different relationship. Community resources, food banks, clothing banks, furniture banks, transportation. We communicate with a lot of different providers and resources around the community. That list changes, and that's one of our barriers is that somebody may be closed and somebody may not have any openings, and so that's a struggle to have that consistent resource available from different community resources. I think Julie's going to talk about this last bullet, working together with other maternal child health agencies. So I'm going to keep going. One of the great things about all this data is they've been able to use the historic data to look prospectively forward into the future, and if the trends continue and if the outcomes continue as they have in the past, we're looking at across the country preventing 500 infant deaths, 10,000 preterm births, 13,000 closely spaced births. You can read the rest of the list. Child maltreatment is another big outcome for NFP that we're able to prevent because of the modeling and the parenting that we're able to do. Violent crimes by youth. You change the family system, and they're employed and educated and have different outcomes than they would if they continued in the places where they are. And also substance abuse. So a lot of really great outcomes come out of this because it's a long-term intervention. It's not I see you in the office for 15 minutes every, few months. This is a long-term kind of relationship intervention. It really changes the family. So these are some of our, here in Birmingham or in Jefferson County, some of our outcomes. So we actually had 64 babies now. We're looking at our preterm birth rate. Right now is still in these very high-risk families is about 12.6%, and then that sounds really high still, I know. But if you look at the fact that in Jefferson County the preterm birth rate for black mothers is 15.2%, we're doing some good. We're changing because all but 3 of our moms are black or African American. So I feel like we're making some progress. There's still a ways to go though. Other outcomes, I don't know why my pictures didn't come through. Breastfeeding and initiation, we're at 80%. We're a little below the national rate, but we're above the state average. We have 99% of our babies are fully immunized. We've got that one mom who says, not getting them, not doing it. Our ASQ developmental screens have been great. Our big issue is co-sleeping. These moms just want to have their babies and sleep with them. And so we have 59% report that sometimes or always they sleep with their babies. So that's one that we're trying to figure out. Any suggestions would be greatly appreciated. Other successes, we've had great reduction in substance use among we really only had a couple who have really had issues in substance abuse. But we've had great success there, reductions in smoking or elimination of smoking while they're pregnant. And then connecting. Our connections have been our other huge success. I know, Matt, we can't get him to respond, but I promise we're talking to him.
Well, I'm excited to get to follow that because you gave I don't have a lot of data because I'm going to be talking about a little bit broader in the system, and so I can refer back to a lot of things that you said and say what she said. So I'm excited about that. So I am here to talk to you about First Teacher, which is the name of Alabama's home visiting system here in i.e. Alabama. It is a federal and state partnership. So you see the little logo up there on the top is for the Alabama Department of Early Childhood Education. They do a variety of things, and they're an agency that we have worked very closely with for a long time, both on the home visiting as well as some of the voluntary 4-year-old pre-K programs. So that's why our logo's up there as well. So we work with Alabama Department of Early Childhood Education to provide the program evaluation and research evaluation on the backside for the whole statewide program. And we'll talk about why it's considered evidence-based in just a minute. But I was asked to tell you what is MCV. I think Candace mentioned MCV, and Matthew mentioned MCV as a federal program. And it is, at least originally, so maternal, infant, early childhood, home visiting. And everybody laughs when you go to some federal meetings about they made it a mouthful because they had to get all the mama people and the baby people and the early childhood people to be happy with this legislation. So this was some federal legislation that actually was established in the Affordable Care Act in 2010. And so that caused a little bit of an issue on the policy side that there were some states that really weren't very happy with the Affordable Care Act, and so therefore they felt like they couldn't even accept the dollars that were going to come to states to establish these home visiting programs because they were opposed to the Affordable Care Act in general. So with that little hiccup, there have actually been some new sections of Title V of the Social Security Act, and so now it's really delinked from Obamacare. So whether you like that or you're for it or against it, you can be for kids and for moms and families. So there's that. So Congress sets the budget, and so states do get these federal dollars, and as of now, all 50 states have MCV programs. Plus an additional 6 tribal areas and or territories that take dollars. So it really is in all states. In most cases, the grantees are the state, but they don't necessarily have to be. They could be a nonprofit. That's the way some of those early programs got around. And for example, Florida wasn't very happy. They signed on to the lawsuit against the Affordable Care Act. So they originally turned the dollars down, but then people were like, but wait, these are monies that can come in to help your moms and families and children. And so they were able to give the dollars to a nonprofit in Florida to run the program. So anyway, a lot of flexibility there. In most cases, they leverage both state and federal dollars so they can build more of a comprehensive early childhood system. So you can see the little quote up there. I think you got the idea when Dr. Knight was speaking that her program, Nurse Family Partnership, is one of the models that can be used, but MCV more broadly is a very broad program. It addresses for pregnant women and families, and they talk about at risk, which can be defined in different ways. The different models have different criteria that they allow or that they'll recruit individuals, but in general, there are some broad guidelines around risk. And it is, again, not just health, it's not just social, it's not just educational programs. It's very broad with the idea of physically, socially, emotionally healthy and ready to learn. So you can see the goals that are there that are really broad there. Again, there's certainly some health-related goals for both mom and child, but also some other issues around preventing child abuse and neglect and encouraging positive parenting and promoting both development early on, identifying issues, making referrals that are necessary so that children are ready to learn when they reach school age. So the MCV home visiting approach, you heard that Candace said these are not our patients. So really the unit of intervention in a home visiting approach is the family. So it's very different. The relationships are really important. A lot of the qualitative work that Dr. Feifelt and Dr. Wingate and I have done, along with some others, is that the single best predictor of how these families actually stay in these programs is whether they've built a relationship with that home visitor. So this is not a medical model or clinical model. It's different. I mean, I've done that other kind of thing as well, but these are not patients. They're not clients. These are families, and they do receive these supports. And it might be from a health professional, it might be from more of a social service professional, or it could even be an early childhood educator. But at the end of the day, these are planned visits. People come in with an idea, they follow a model. We'll talk about that in just a minute. And we know that there has to be some flexibility, because just because you plan to talk about breastfeeding today and you find out that they're about to lose their, they're about to lose their apartment, you probably have to change your plan. But there are some planned visits that plan in advance, and some pretty broad Again, not just health, not just social, not just education. So what does Alabama's program look like? I was asked to talk about that a little more. So we know that there's across the board. The Department of Early Childhood Education, we call them DECE, was designated by Governor Bob Riley at the time to be the lead agency for home visiting. Doesn't mean they're the only people that do home visiting, but it does mean that they were designated by the governor and continue to be the lead agency for home visiting. So they do provide funding. They receive all of the federal MICV funds, and they receive a pretty big portion of some state dollars that support it as well. So they are really the foundation of the early childhood, at least home visiting system, notwithstanding some other programs. And these have to be voluntary, and so therefore you can't require a family to be a part of it. It can't be somebody's plan because they run afoul of Department of Human Resources, or maybe they're a high-risk pregnancy. In order to be, and that's not because DECE wants it that way, that's because MICV requires that. You cannot force a family to be a part of it. So these are voluntary services, and in Alabama, they're all delivered through local communities. So this is not the state coming in, setting up something that requires people to do something. These are people's neighbors. These are people's local community. They know their communities best. And again, Alabama uses one of three, they use at least one of the three evidence-based models. Now, when we talk about evidence-based, Dr. Knight mentioned the extensive research behind the nurse-family partnership model. So in 2010, when this program was established, there were at that time 14 models that they felt like met the research rigor to say there's some evidence that these have some positive outcomes. So states were allowed to choose from 14. There have been more now, but all of those have varying levels of research. They're implemented differently, but there's some, at least they're evidence-informed, if not evidence-based, that there's a possibility for some impact. So I mentioned that we get to play ball with them, which is very exciting. So these are the MICV benchmarks. We call these would be our program goals, and you probably saw from Nurse Family Partnership how well those align with what they do every day. Again, their model is one of the 14 that could have been chosen. And so, again, very broad. There's certainly health and beyond, and school readiness, which was a little bit of a challenge when we first started working with folks, is because each of these models came in with a hat that they probably wore best. No offense, I know what you said, that you're not just health and you're not, and some of the other models are not just education. But we kind of come in with what our best skill set is, and so it was a nice growth opportunity for everyone. And so there are 19 required constructs or measures, and so you have to, every year we work I'm looking at Heather and Eric, who's not here, who just submitted ours on behalf of the state of Alabama. So every year you're held to very rigorous standards for, are you making progress in these areas, and continued funding is only available if you make progress in these areas. So there's a lot of accountability there. So in Alabama, you heard a lot about the Nurse Family Partnership. The other two models that we use here in Alabama are Parents as Teachers and HIPPY, which isn't that funky? That's so funny. Home Instruction for Parents of Preschool Youngsters. And so both of those three models were chosen because states were given the flexibility again. We were required to do a needs assessment. So Dr. Wingate and some other folks who are here and now not here, right? So anyway, we worked with the state on a needs assessment. And the idea is that for the federal home visiting programs, you're supposed to look at prenatal all the way through kindergarten age, so birth to 5. And they gave us very specific stratification around risk and what risk means. And so through stuff that I won't go into today, we basically were able to provide some risk profiles by counties back to the state. And they determined that we really wanted a system here in Alabama that would allow prenatal entry all the way through, covering families up through kindergarten age, and families whether it was their first child or their third or their 10th. And so those three models were selected because they were already in the state to some extent, and they met the criteria, and they gave that breadth across the system. And as you mentioned, there are the states, each model has its own very specific criteria that it must follow. So unfortunately, it's probably difficult sometimes because they have to wear their model hat, but they also have to wear their first teacher jacket. So they're part of, we talk about that a lot early on, that's been some of the challenges that we've faced, as standing back from the back and helping people that kind of like their own little lanes, but how do we think through that? And they have to maintain fidelity to their model, so they have to deliver their model the way the model was structured, but also adhere with what's required. So you heard a lot about Nurse Family Partnership, so I won't redo that, but I will just to point out Parents as Teachers is different because it's not nurses. It could be, but it's not. Those are parent educators, and so sometimes they have bachelor's degrees in child development, sometimes they're social workers, They may have other early childhood experiences. They have a little bit broader educational. We try to our state tries to make sure that they do at least have that college degree, but that is not a 100% requirement, but most of them do. And they can serve prenatally all the way through kindergarten. So they could enroll prenatally, but they might also enroll. There's no limitation on what age or how many children you have already. And then HIPPY is a little bit narrower. Those are what we call peer parent educators. Very often these are families who their child graduated from the program. They themselves were clients in this program, and then they turn around and sort of do peer support with others. So they have just variety of backgrounds. And they focus on children ages 3 to 5. And again, all three of these programs have to go for model training, and very extensive, as well as we here at UAB provide training for them around the measures that are required in using the data systems. So we laugh. You can wear your hat for your model, but you have to wear your jacket for first teacher over the team. Here's an example of federally funded. Those red counties are all the places that there's federally funded first teacher. So that means counties that we count because they have at least one caseload that was funded by the federal program administered by DECE. And it gets a little broader. If you can see now, all those dark colored counties, those might be state funded. So they might be federal and or state. But you can see that they're fairly well blanketing the state. There are clearly some areas that aren't. Again, it's a blend sometimes of federal and state, but for the most part, they're there throughout the state. Not that there's not a lot of work to do, but it's a possibility. I wanted to put this in here because there's a new focus and a new opportunity for home visiting to grow even more. The governor's office, newly elected now, Governor Kay Ivey, has released some money again to combat this issue related to infant mortality, and with our continued poor performance in that area, home visiting is receiving about half of the dollars that are going to be released by the governor, because the idea that it can address some of the root causes, either direct or indirectly related to infant mortality. So, a new opportunity for expansion. We're excited about that. And I just wanted to close, and then I know this is a question you may have later, but I wanted to mention, there's some successes. We count just the federal funds right now because the state fund it's a whole story that you can talk about later over maybe an adult beverage. But we are working with them. We can count the families there, and so we're looking at over 2,300 children just with those federal dollars. In nearly 2,000 families. And there's been significant expansion since we started in 2010. It started in 3 little counties. There's been just significant expansion of access. The program has consistently met benchmarks. It takes a lot, it takes a village to do that. You can looking at people on the team back there and talking about the monthly monitoring and all the supports and using of data and helping people get the professional development that they need and using data, but it's there. And the partnerships and systems development have been incredible. People reaching across the aisle, people looking for ways to help fund themselves, health and education playing in the same sandbox, which is just a dream of mine, and it happens. Also, Medicaid has just come on board, and they're going to allow some Medicaid matching for both the Parents as Teachers model and the Nurse-Family Partnership, so dollars, people show up and they actually want to do more, so it's even better. But there are plenty of challenges as well. Even though I showed you those pretty maps that have a lot of dark-colored counties, the demand for services far exceeds the capacity. You can imagine it's these relationships, and they're seeing families regularly, up to twice a month, sometimes more if they were to need that. So you can't have huge caseloads because you can't provide what you need, and it's very expensive. The models are expensive. It's just expensive to do this. So the demand far exceeds. There are long wait lists in many places. And the research evaluation results, honestly, on the system outcomes are a little mixed. It's hard to tell the story. You alluded to the fact that your preterm birth rates are higher than Alabama. Well, I'll tell you that's the same case here if you looked at the system that we monitor. And but again, we're serving the most at-risk, the highest risk families. So there's some good news in there, but there's how do you tell the best story that really shows what you're doing over time. And when you do a screening for depression for a mom and then find out that there's no service to refer her to, then it's a failure. It looks a failure, and it's really a system issue. So those can be real challenges. And then finally, we already talked about this with my disclaimer with Candace ahead, that it's been difficult over these 8.5 years to manage some of the issues because there are models and different people and even different agencies that fund home visiting. And people really want it to be a little territorial, and they worry because they have reporting requirements and accountability requirements, and I have to serve this many. So they don't want to think, when we think a little broadly about how can you make sure that families are getting what they need regardless? And so, we've been doing a lot of work with the state and partners to think through meeting the needs of families, and can you think about a continuum, or what we're talking about now with some centralized intake to triage families who really need that because they're very high risk medically, or they're prenatal, maybe they need nurse family partnership that's available, but then when those children graduate at 2, if they continue to need service, now they go into parents as teachers to follow through their 5th birthday. So anyway, that's some exciting stuff, and I'm going to turn over to you to think bigger, broader even.
Great. Yes. Well, yeah, this is really exciting, and I'm just seeing all the parallels to what being done here in Alabama and what we're doing overseas in Kenya. So it's going to be an interesting. I hope we have time for a discussion. So, I've been working in some different home visiting approaches for enhancement of prevention of mother-to-child transmission of HIV, but also more broadly family health in Kenya. And so just very, very brief background on Kenya. The HIV prevalence nationally is around 5 to 6% at this point, but they have a huge population of people who are living with HIV. As elsewhere in sub-Saharan Africa, HIV prevalence rates tend to be higher among women than among men. And maternal to child transmission of HIV is a continuing health problem. Progress actually has been made in recent years, but we know in developed countries or in the U.S., rates of mother-to-child transmission of HIV can be as low as 1 to 2%. When pregnant women get on antiretroviral drugs, their viral loads are very low. They do not transmit to the child. So we know this is possible globally, but in Kenya, as our most recent data, we have still around 8.3%. The area of Kenya where I'm working is in the Nyanza region, which is over on the western side of the country on the shores of Lake Victoria. And this is a part of the country which has traditionally and continues to have much higher rates of HIV than elsewhere in Kenya. About 15% of the population of adults of reproductive age are HIV infected still at this point, even higher among pregnant women. So we've been doing a series of studies to figure out strategies to address this problem and reach pregnant and childbearing women and their families and promote their health overall. So one of these approaches is what's called the Jamil Bora study, which means better family in Swahili. And through a series of studies, we've realized that just reaching out to pregnant women and mothers alone is not getting us the impact that we need. And we've realized that women really need the support of their husbands, their male partners, to be able to make a difference in family health. And so based on a lot of observational studies, we came up with this idea of a home-based couples intervention. So, which is going to help, one, couples to test together for HIV so they both know their status, but also to give them a comprehensive information about family health during pregnancy and after the birth. And so we feel like if we reach the couple together, we have a potential to help them make better health decisions, increase their use of health services, and improve maternal, paternal, and infant health. Yeah, so I haven't heard a lot about men in the previous, even though you've talked about families, but we really have very consciously tried to involve men. So this intervention is, and this was tested in a pilot study that we completed recently. So we did 3 home-based visits for pregnant women and their male partners together as a couple, 2 during pregnancy and 1 after the birth. We included couples of all HIV serostatus. Some of them were both positive, some of them were negative, some of them were discordant. Now our counselors, and this is part of the special thing of this strategy, is we have a man and a woman visit the home together. So we have 2 counselors. They are lay health workers. They are not nurses or doctors. In this kind of a setting, nurses are a premium, and we don't have that many nurses, but we rely a lot on lay health workers who are trained to do this specialized counseling. And so the visits include maternal, child, and family health information. Another interesting thing that we've added is couple relationship and communication skill building. So we have specific content where we work with couples to improve their relationship and how they communicate together about issues. We offer them to be tested together for HIV as a couple in the home, and we link them to all sorts of services. And so the pilot study was very promising. We found, not surprisingly, when you go to the home and invite people to be tested together in a private setting in their home, there was much higher uptake than in the control arm where the men were invited to come to the clinic and never showed up. So that maybe is not surprising, but we did see a huge increase in our intervention group. But we also saw some promising trends in terms of other maternal and child health outcomes. And again, this was a small pilot study. We had 60 couples in each arm, very small, but we saw, positive trends in getting men to come to antenatal care visits, women giving birth in a health facility. We had statistically significant results, increases in exclusive breastfeeding and maternal postpartum checkup. So those were some positive trends that we saw that have encouraged us to take this strategy further. So just currently, we are just getting started on a much larger trial of this intervention. And this is actually going to be, this is a large randomized controlled trial of 1,000 couples. Yikes. A big sample that we're going to be randomizing to either this home-based couples intervention, another strategy where we give them the ability to test as a couple for HIV privately at home with HIV self-test kits. So that, another way of trying to engage men in HIV-related health. And then we have a control arm. And we're going to expand we're going to have 5 visits now in our new strategy. We are going to have 2 during pregnancy, 1 early after the birth, 1 at 6 months, and 1 at 12 months. And we're going to be able to look at more long-term outcomes and effects. And just briefly, I'm going to talk about one other strategy that we're testing in a different study. And so this is another study where we're looking at, again, in a similar population. This study is only among pregnant and postpartum women who are infected with HIV already. And we're trying to figure out how we can help them to take their antiretroviral medications and stay engaged in HIV care. And this is called the Motivate study. And we're testing some different interventions to try to support these women, but one of them is called the community-based mentor-mother intervention. And the other strategy that we're looking at is a text messaging intervention. So basically, these community-based mentor mothers, mentor mothers is a model that has been used throughout sub-Saharan Africa, where women who are infected with HIV themselves become peer educators. And so in our case, these are women who have already been through prevention of mother-to-child transmission. They have an HIV negative baby, and they're going to help their other women with peer education and psychosocial support. And this has been a very effective strategy throughout Africa. In Kenya, it was developed nationwide as a program, but these mentor mothers were sitting at the health facility. They were based at health facilities, and so they would interact with women who came to the facility, but they wouldn't have any outreach into the community. And so what we said, okay, we've got to bring this out to where women are who actually aren't maybe even coming in for services. So what we're testing is the community-based mentor-mother model. So women go out and do a series of home visits with pregnant and postpartum women who are living with HIV. And here you can just sort of see the schedule of visits that we have, not quite up to 64 visits, was it? But still, I feel like this is pretty intensive. So, they get monthly visits during pregnancy up until the birth, and then a series of visits that come at different key time points after the birth. But this is an ongoing study that we're just wrapping up and do not have yet the results, but we're going to be very excited to see them. Just to show that there are a lot of people that are involved in this work that I want to acknowledge, including our colleagues at the Kenya Medical Research Institute. And I also just wanted to show you may see some familiar faces here from UAB. We've had several UAB students and other faculty members involved in this work, and we're excited to keep it going now for some more years. So I think I'll end there.